So welcome everyone to our sixth investment and payment work group meeting. Thanks so much for joining us this morning. We really appreciate you being here. If you wouldn't mind letting us know that you are here by typing in the chat your name, your title, your organization. It's really helpful to get the conversation started. And then, of course, joining me this morning are members of the OHCA team and our partners at Friedman Healthcare. So I will bring up these slides. And today our focus will be on focusing on the alternative payment model. The alternative payment model standards and implementation guidance, and then also discussing the goals and definitions. And then we will kick off a discussion of primary care investment. Can you all see that okay?
Yes.
Thank you. Okay. So I just quickly overviewed our agenda. So again, focusing on our alternative payment model standards, the revised standards that we shared via email, and then also discussing revised proposals for the APM goals and definitions. And then we'll get into an initial discussion about primary care investment. And just as a reminder of our meeting format, so again, feel free to use the comments or the chat to ask questions and make comments there. We track all of those and they're really helpful for us. And then I did want to a new item is that we are hoping to get all of your feedback on how the work group has been so far for you. We're kind of at a little bit of a midpoint in the work group's timeline as we shift our focus from alternative payment models to primary care spending. We would like to get your feedback via survey on how the work group has been so far, the value of meeting material, the pace of the meetings, the level of detail provided, and looking for your feedback on how we can improve kind of in our next half of work group meetings moving into 2024. So we will be sending out a survey link via email following this meeting probably later this week. And so look forward to receiving your feedback on how the work group has been so far and any suggestions for improvements. So I will jump into our first agenda item and we'll pause after each agenda item, of course, and then to have questions and discussion. So again, really appreciate all of the feedback we've received so far on the APM standards and implementation guidance. Today, I'll share revised APM standards, and you also received via email the full complete draft of the APM standards and implementation guidance. And they're also included in the appendix of this presentation. So jumping into our first 5 standards, wanted to note here that on the slide, the blue text indicates where we have made changes or revisions to the standards based on all of your feedback. So standard number 1 has been revised to emphasize that the models improve health, affordability, and equity. So really focusing on how alternative payment models should improve health, affordability, and equity. And then standard 3 has been revised to more clearly articulate the role of primary care and other preventive services in creating lasting improvements in health access, equity, and affordability. So we've restructured standard 3 to really focus on spending more upstream in terms of primary care and preventive services. And then we didn't make any changes to standards 2, 4, or 5. We may have made some revisions to the implementation guidance that you'll see in the details, but there are no changes to the standards themselves. Now moving to standards 6 through 10. Again, here the blue indicates the revisions that we've made. So in standard 7, we revised to emphasize that measuring and stratifying performance is the key here, with the intent to improve population health and address inequities. And standard 8 has been revised to really emphasize and promote investment and strategies that address inequities in access and outcomes. This was previously focused more on data, and here we're emphasizing that the investment needs to be made to address inequities. And again, there are no changes to standards 6, 9, or 10. So I will pause there for questions, comments, additional feedback. We, just as a bit of context for next steps, we're sharing these revisions here today, and then we'll be sharing also the draft alternative payment model standards and implementation guidance with the advisory committee at the end of November. So those are kind of our 2 key next steps for the alternative payment model standards. And I see Beth has her hand raised.
Morning. So there are a lot of really good changes here that I want to start by appreciating and thanking everybody who contributed, and all of the staff and consultants who've polished multiple inputs. Of course, since you made some changes, we have some suggestions to add to slightly improve. For example, there's a new provision on using technology to facilitate access, and we just need to acknowledge that not all populations have the same access to technology. Things like that. I also very much want to appreciate, and it's not here in the slides, but it's in the red line, the first footnote. The chair of my dissertation committee would be so proud of me. The first footnote, which acknowledges that trying to adhere to these standards and guidance does not eliminate or obviate the need to get a license for entities accepting risk. And so I really appreciate that acknowledgement of existing California law. And thank you for that. So good work, guys. More comments to follow. Thanks.
Thanks very much, Beth.
Hi, good morning. It's oh, sorry, I'm not raising hands, so I will raise my hand. Hold on.
Go ahead, Moet.
Okay, good morning. One of the things that I've been punting around with several of the agency leads is the definitions and availability of the RELD and SOGI data. And something that given the work that's happening across multiple agencies right now, my fear is that everybody's going to go down pathways on their own in terms of what level of data is allowable. So for example, in covered California reporting, it has to be the self-identified, data in the record. But for broader REL reporting, one of the things that we're encountering, even with the DMHC right now, is that employers don't necessarily share this data, right? Even if employers have the data for EEOC purposes, for labor law purposes, they're not readily delivering that data to those of us who are trying to do PHM models, right? And then similarly under DHCS is already up and running with a PHM model where they're asking for all of these data to be included. So, in conversations with Michael Valley, I'm really, really hoping that before we get too far down the path, that we get some interagency cooperation to come to an understanding of what is usable, where that data can be found, and if it is not available today, what are the plans to make it more available for these purposes? Because I think the stratification simply does not work if you can't get the data into the right spot. So sorry, but it's been my thing for the last month. I can't wrap my head around how are we going to do stratification? How are we going to do focused intervention? How are we going to do equity-based plays as we move forward without agreeing on what is usable and verifiable data?
Yeah, I mean, I would just say we recognize that that is a challenge and that, in terms of the context of the standards are really intended to be best practices for alternative payment model contracting. So we think of, measuring and stratifying performance as a best practice to address inequities. And I think we all across the state recognize that, we have a lot of work to do to improve self-reported race ethnicity data and are very much collaborating across state departments and can follow up, to check in with our sibling departments and others to make sure that we're all on the same page here. But it's very much an issue that we continue to collaborate on. And Catherine.
Thanks. And like Beth, wanted to add my thanks for being responsive to feedback. Terrific to see these changes. Specifically appreciate the addition of disability status in the demographic data under 6. One small but I think important addition would be to add patient experience to item number 8, investing in strategies to address inequities in access, patient experience, and health outcomes.
Thanks, Catherine. Thanks for that feedback. And Beth.
Oh, just to say, as someone who's struggled about race, ethnicity, language, and disability status data for many years, it's terrific to hear that Anthem is worrying about it. It just as so much of what we're talking about with the APM standards is aspirational. Getting that data and doing the stratifying and educating employers, Medi-Cal eligibility workers, and a lot of other people about the importance of having the data will be part of the challenge going forward. And it's I would put that in the category of good problems to have. Thank you.
Thanks, Beth. Any other feedback or thoughts on the revised draft of the alternative payment model standards and implementation guidance? Yes, Kevin.
Yeah, Margarita, again, yeah, thanks for all the great work on this. It sounds like, people like Beth, there's probably a few of us who have a few wordsmithing a little bit here or there on, particularly on some of the details. It sounds like you're open to just having us email you and things like that with suggestions. It's not put to rest and it's totally final version yet.
Of course not. It is not final in any sense. This draft, we're sharing these revisions today with you, and then we will take this version of the alternative payment model standards and implementation guidance to the advisory committee at the end of November. And that essentially opens up another round for revisions and feedback. So of course, welcome all of your feedback. In a kind of an ongoing manner if you want to send it early, or you're welcome to wait until after the advisory committee. And then we will debrief probably in January or December, I forget our timeline, about the advisory committee feedback on the alternative payment model standards. So we'll bring that conversation back. Okay. Not seeing any other hands raised. And I think thanks, Dr. Solomon, for the chat. We can look into that as well. So if there are no other considerations or thoughts on the alternative payment model standards and implementation guidance, we'll move to our next agenda item, which is revised APM goals and definitions. And these are revisions based on our discussion during our last meeting. So to start this discussion or to start this section of the presentation, we wanted to give a refresher on kind of the key decisions, the key strategic decisions that we're thinking about in terms of developing the alternative payment model goals. And We'll also talk about the work group feedback we received and then present a revised proposal for the alternative payment model goals. So our kind of 4 key strategic decisions are: should certain types of payment models count towards the APM adoption goal? And should goals vary by payer type or by product type? What unit of measurement should APM adoption goals be based on? And then how should the goals be structured? And then in this next slide, we'll review just a summary of some of the feedback we heard during our last discussion about the APM goals, and then also feedback we received, via email or offline. So generally we heard, support for inclusion of the HCP land categories 3A through 4C, and those are the categories, from shared savings through population-based payment. And then we heard that, folks were interested in the link to quality, so therefore we're supportive of the exclusion of 3N and 4N, which are those types of payment models that don't have a link to quality. And then we also heard some feedback that we should consider inclusion of 2C arrangements. And again, heard support for the link to quality and kind of variations on how we should define that link to quality, which we'll be talking about in a bit. We also heard that, aligning the HCP land category 3A and 3B minimum shared savings or loss thresholds with existing models would be helpful. And then we heard some feedback that we should consider an absolute improvement goal with stair steps, and also consider whether to vary the stair steps by payer or product type to recognize the different starting points that different payers or products might be at. Then we also heard that APM adoption goals should align across payers, and that we should monitor APM adoption across multiple metrics, especially percent of members in alternative payment model contracts, or covered under alternative payment models, and then also the percent of total healthcare spending in APMs. And then we wanted to kind of recognize here that there are questions on the pathway forward for self-insured and fully insured PPO plans. And we're aware of these questions and are communicating with DMHC and others about these. We also just, as Beth mentioned, we added a footnote in the APM standards and implementation guidance that any organization taking on significant risk needs to be regulated by DMHC. And then, of course, anything we learn in our conversations with DMHC, we can come, back to this group and share and make sure that we're all on the same page in terms of how self-insured plans and fully insured PPO plans can participate in alternative payment models, and what are the options for those types of plans. So getting into our set of revised recommendations. So in kind of to answer our key question number 1, whether certain types of payment models should count towards the APM adoption goal here, we didn't make any revisions to this proposal in terms of focusing on payment models 3A through 4C. But we have clarified kind of the link to quality and wanted to walk through how we're thinking about that. And so here we've defined that payments are considered linked to quality if the provider is eligible to receive a financial bonus or is at risk for a financial penalty based on performance on specific predefined goals for quality. So, for example, if a provider received a performance payment in recognition of quality performance in addition to their capitation payment, then that capitation payment would be considered linked to quality. And as another kind of specific example, want to walk through how this program or this definition intersects with the Integrated Healthcare Association, the IHA Align, Measure, Perform program. So in our discussions of the link to quality conversation, we've heard that some participants in the Align, Measure, Perform program are eligible for additional payment based on their results, and others are not. So under this definition, if capitation payments to AMP participants would only count as a link to quality if providers were eligible for a financial bonus or a penalty based on their AMP performance in the program. So, and the penalty or bonus could take many shapes and could be separate from the capitation, but that's kind of an example of how we're thinking about it. So in, the AMP program that's widely used across California, there are some provider organizations that are receiving bonus payments or incentive payments on top of their capitation, and others are not. So if those others are not receiving those bonus or incentive payments, then they would not count towards the goal as a link to quality. And then also we've in the appendix, we've provided full details about the definitions of the minimum thresholds for shared savings and risk. And those are in our appendix with the expanded non-claims payments framework. So I'll go on to our next three key decisions. So key decision number 2 was, should goals vary by payer type, commercial, Medi-Cal, Medicare, or by product type? And here we've specified that the absolute improvement goal should not vary by, or, we're recommending that it does not vary by payer or product type. And then recommendation 3 is, our focus on answering the key questions of what should the APM adoption goals be based on. And we revised the goal here to clarify that measurement of APM adoption. We are proposing that it be based on the percent of members, which we heard support from workgroup members, and also have done some internal efforts to figure out whether that was feasible and how we could do that. And then note that we will also monitor the percent of total healthcare spending in each HCP land category, along with using the goal based on percent of members. And then for the note here, that we were in working with IHA, they've noted that they found little to no difference in the percent of members attributed to an APM and the percent of total spending. So those can be quite aligned. And then for key question number 4 in our recommendation here about how the goal should be structured, we're proposing that the goal specifying that the goal will follow a stair-step structure with an absolute improvement target by 2034, and that the steps along, getting to that absolute target will recognize differences in starting points. So in summary, this is our proposed recommendation for the alternative payment model goals. Again, here, the goals are based on the percent of members attributed to the HCP land categories 3A through 4C. And they are structured as stair steps, with all payers expected to reach 75% adoption by 2034. And that all qualifying APM arrangements must be linked to quality in order to count towards meeting that goal. And that, again, all qualifying HCP land category 3A or 3B, those shared savings and shared risk models must meet minimum thresholds for the shared savings and shared risk amounts. So in the table, we've specified the stair-step goals with a path for each payer type to reach that 75% goal by 2034. And to recognize differences in starting place, the initial goals vary for commercial PPO plans, and we're proposing kind of a faster improvement track for PPO plans in order to meet that absolute goal of 75%. So I will pause there for questions and discussion. And I see, yeah, Mohit, you have your hand raised. Go ahead.
So one of the considerations that we constantly
Mohit, I think you've frozen, or Mohit's frozen for me. I don't know if others can.
Yes, for me as well, Margareta.
Okay. Let's see. Maybe Kevin, do you want to jump in and we can send Mohit a chat?
Sure. Actually, speaking of chat, I don't know if it's just me, but my chat isn't working. Is that just me, or are others able to communicate by chat?
Oh,
I gotta like can't send messages because not a member of a chat. I don't know if that's a central issue for the OHCA folks who are tech support.
we'll look into it. It looks, I can see other folks
Okay,
chatting.
maybe that
So,
is just my team's. But maybe then you'll be spared all my sarcastic chats that I would never come right out and say, but I will miss your chats. Hey, one thing, Margarita, I think these all look good. I know I was the one who made an issue of, well, what about just pure all capitation? I'm fine with saying, yeah, it'd be good if it has some then component of quality incentives. I'm realizing though, I wonder if somewhere in our report, we want to express a bit of humility about quality measurement. I think there is a whole movement growing about the very disease-specific, reductionist quality measures and the whole problem of, study for the test, and that, yeah, you can get all the A1Cs and blood pressure, but is that really making people healthier? Is that really focusing on what people really need? So I'm also a little wary when, all these incentives are going to be linked to 83 different, very specific quality measures, that there is a trade-off for that, where people focus so much on that sometimes they're not really able to focus on whole person care in a way that patients really want to prioritize. So I'm not saying throw the baby out with the bathwater, but you know what I mean? I'd like just us to probably acknowledge that the state of the art of quality measurement and really understanding how that translates into holistic, better health for people is not terribly mature, and we need to be wary of some of the trade-offs of going down that road. I don't know if others share that concern, but it certainly worries me with a lot of the quality payment models.
Thanks, Kevin. Yeah. Any other thoughts on that? Or Beth, I don't know if you had a related thought or.
Well, somebody who sat through the quality measure discussion in multiple other state agency settings, I mean, I think at this point we're on track to 5 to 10 measures, and I don't know if that makes people like Kevin feel better or worse. It's certainly the case that there are, it's a tougher thing to do than it would seem, and to the extent that we're dependent on survey data with all the limitations, especially for subpopulations that involves, it is even more limiting and challenging in terms of quality. I wanted to come to a different piece of this, which is when we're talking, and I think this is in the footnotes of the appendix, heaven help me, that on the HCP land 3A and 3B, I think we're talking about 25% at risk, if I'm, or 25% savings. I think that when we get to what's actually going to change behavior, as well as what's taking sufficient risk that things move into a different category, I think we need to, that's not a detail, that's an important consideration, as best I understand what we're talking about. Thank you.
Thanks, Beth. Yes, it is, it is a key consideration in terms of the shared savings and shared risk models. We, in our recommendations are emphasizing that there be, potentially a substantial portion of the payment at risk for performance to, provide those incentives for care transformation, improved quality. But, you know, those definitions are also, you know, up for feedback and recommendations and revisions. So welcome any feedback on those definitions.
Yeah, there's a trade-off here between changing the incentives enough to change behavior and making sure that consumers are actually getting care. And I want to say it in that basic a way, because we have a whole structure of law that's aimed at that with respect to capitation and other forms of delegated risk.
Thanks. And Adam, go ahead.
Thank you. I guess a couple of comments. One is I agree that we do need to be walk a little lightly on some of the quality metrics. Sometimes they're hard to define, and you can look at process metrics versus outcomes, and either way they're not always precise and end up where you really want to be. So sometimes I agree that there can be playing to the test, and then also having too many measures can be problematic. At the same time, there's a comment about not necessarily having quality results being compared to other organizations, other groups, and being a baseline. And my only concern with that is similar to what we saw during the pandemic, where across the board, a lot of groups struggled because of things outside of their control. And relatively, there were some groups that still performed well, but maybe not as well as you might have hoped if it was normal circumstances. So I think that comparison helps over the course of time. That also brings up the metric of one is the improvement and the other is achievement, and ensuring that we keep in mind both. And then one other on the statement of APM absolute improvement goal. To me, it's unclear the way that is phrased of whether we're talking solely quality improvement, or if some of this improvement expectation is around cost and other types of utilization metrics. And there's definitely a correlation between outcomes and overall costs. But I don't necessarily want to lose the forest for the trees there. Ultimately, we're trying to get better outcomes, which should reduce the costs, and that is sometimes a more tangible metric. So those are just a few comments. Thanks.
Sure. Yeah. So I think maybe I can kind of recap or rephrase the absolute goal and see if that helps clarify a bit. So in terms of the absolute goal, we are looking at measuring the percent of members that are covered under alternative payment model arrangements. So categories 3A through 4C, and measuring progress towards that absolute goal. And, with the, if we kind of buy into the vision of an alternative payment model, that it will lead to better outcomes and affordability and improved affordability, that's kind of what we're striving for in terms of more members, more Californians covered under alternative payment model arrangements. And I think, all of the discussion about in terms of like how we define quality and how we think about quality are very much related, but also, have, potentially is maybe not as tied to how we set the APM goals, but thinking about like what are our quality measures and quality programs that we use in California. And I think I see Hillary with your hand raised.
Yes, thank you. So I just had a question about the recommended APM adoption goals and whether or not this takes into account any like network adequacy issues or access issues that might come up. So in other words, like what happens if these goals are not met, or, are payers going to be expected to drop providers who don't want to participate in an APM that we have? So I would just be interested to hear your thoughts.
Yeah, I would say, these goals are not you know, as with like the DMHC regulations for taking on risk, these goals do not obviate the need for network adequacy or access requirements or things like that. So these are very much intended to be, you know, aspirational goals for us as, you know, an industry in California to work towards in terms of, you know, getting to those better health outcomes, which is really, you know, the goal through an APM model is to incentivize better health outcomes. And so, yeah, you know, these goals would be, you know, something we're working towards together as across the state, but they would not, you know, interfere with any, you know, DMHC or other regulations that payers need to meet or other providers need to meet. So, and again, you know, these goals are intended for us to work together and to kind of work towards increasing APM adoption with that goal of overall improved health. But they are not enforceable. These are really intended to be, you know, goals for us to work together as an industry to transform care and payment to incentivize health outcomes, but not enforceable. And Reshma, go ahead.
Yeah, I actually, I like that last question because I think it does come to this piece around that, like, what is our role with that relationship between the payer who's contracting with the provider on some of these? And I think there is a component that actually was not on my radar when I was reviewing it, but I was just thinking about around language around if a provider, for you know, it's the providers kind of making sure that we're promoting them towards staying in these contracts and being able to coach them through it. So it's from the vision of those providers, you know, starting from a different place, having more difficulty kind of reaching certain outcomes, that there's a decision on the payer side too to kind of work together in a coaching environment. So I imagine there may be some language that we could use that's just saying that if we're not meeting goals, then don't just cut folks out. And that kind of perspective is coming from some of the work, Medicare that I've had before, in which if folks were not meeting some of these goals, especially there's certain metrics, right, that they struggle with the most, and it's usually around utilization or cost. That there's kind of like that monitoring period, right? And like that period often we don't talk much about. It's kind of left to whatever happens with every organization happens to make those decisions. But there may be some kind of broader language around like what you're saying as themes of practice or best practices to say something about if we're not meeting those goals, there's a period where you're not just dropping and releasing. And you're actually trying to give like almost like a remediation period or something. And I think there is variability that you see across the board in how those situations are dealt with. So we can't micromanage that at this level, but I do think there may be a component of a statement to say that best practice is if we're not meeting the goals, there is some remediation, something. And I don't know what the right terminology might be. I don't like the word remediation, but that is essentially what I'm trying to get at. I don't know if others have thoughts on that, but I think that's actually an interesting point.
Well, I definitely think we can think about, excuse me, in the APM standards and implementation guidance, some of our focus has been how to get, you know, more providers engaged in alternative payment models and support them through the process. So if there are ways for us to adjust or kind of re-emphasize that in the standards, we can definitely look at that. Any other thoughts or kind of reactions, feedback to the goals? Okay. No excitement, no interest. Okay, I'm going to take silence as somewhat of a lukewarm excitement towards these goals and welcome your feedback as we move forward. Again, we will present these goals to the OHCA Advisory Committee at the end of November and continue to iterate on these goals based on feedback from the Advisory Committee and any further feedback from you all. Okay. I think with that, we are going to turn it over to our next agenda item and kind of kick off our focus on primary care investment. And Mary Jo and Vinayak will walk us through a set of slides to introduce the work on primary care investment and also talk about some of the discussions we've been having in our primary care subgroup. So I'll turn it over to Mary Jo.
Thank you, Margaretta. All right, let's go ahead to the next slide. So on this slide, we have the timeline for our primary care work. We held the initial primary care subgroup meeting in November, thanks to all who were able to attend that meeting. Subgroup meetings will also be held in December and January. After introducing this topic to the investment and payment work group today, we will discuss measurement recommendations with the subgroup in December. And then in January, we will sort of continue those discussions before moving on to benchmarks in February with this full group. Our goal is to bring an early draft of the primary care definition and the benchmark to basically have that ready in March. And so we'll be working with the work group, this work group, as well as the subgroup to incorporate all of your input and have something ready to go to the advisory committee in March. Obviously, we'll continue to refine those along the way before bringing drafts to the board for discussion and public comment in May. And then we'll incorporate the board's input and bring a primary care investment benchmark to the board for approval in July. Let's go ahead to the next slide. Just wanted to take a second to provide an overview of the statutory language associated with OHCA's work on primary care and behavioral health investments. The statute requires that OHCA promote system-wide investment by measuring primary care and behavioral health spending against spending benchmarks. And the goal of the benchmarks is really to motivate building and sustaining infrastructure and capacity, and specifically types of reimbursement that shift healthcare resources and investments away from specialty care and towards innovation and care improvement in primary care and behavioral health. If you go to the next slide, this section of the statute addresses promoting improvements in the delivery of primary care. I find it to be helpful guidance to review in developing a definition for primary care. It provides some background and context for thinking about the services and providers and service settings to include in a definition of primary care. So, for example, the statute notes the importance of telehealth to expand primary care access. So OHCA would likely develop a primary care definition that includes primary care services delivered in a telehealth setting. All right, let's go ahead to the next slide. You know, it's always interesting to start with sort of this big picture question of why primary care. And in addition to recognizing that a high functioning healthcare system requires a foundation of high quality primary care, we want to highlight some findings that really demonstrate the efficacy of investing in primary care to improve outcomes. This is a report that many of you may be very familiar with. It was published by the National Academies of Sciences, Engineering, and Medicine back in 2021. And it really, I think, very clearly communicated the need to rebuild the foundation of healthcare as primary care. And in turn, it found that increasing supply of primary care services leads to more equitable outcomes and improved population health. I also want to take a second to just note how primary care investment in California currently compares nationally and internationally. So in 2020, which is the most recent data that we have available, primary care investment in California was about 6.3% of total spending across all payers and all payer types. So commercial, Medicare, Medicaid, et cetera, compared to about 4.6% nationally. Primary care investment in the United States, though, typically ranges from about 4 to 7%, which lags other high-income nations with higher performing healthcare systems. And in these countries, primary care investment tends to be about 12 to 15% of total spending. So while California was higher than the national average, it's still only about half of what we see in those countries that have the highest performing healthcare systems. If you go to the next slide, this is just a map that shows how other states compared in that same study referenced on the last slide. So this is a 2023 study by the Robert Graham Center. The Robert Graham Center had some funding from the Milbank Memorial Fund to complete this work. It shows the range of primary care spending as a percentage of total healthcare spending across 19 states. Those were essentially the 19 states in which there was sufficient survey data from the Medical Expenditures Panel survey to do the analysis. Among these 19 states, primary care spending varied by a factor of more than 2, ranging from about 3.2% of total spending to over 7%. If we go to the next slide, the next several slides actually sort of highlight how other states and national policy leaders are really taking note of the growing interest in primary care. And I would say the growing commitment of many states in increasing primary care investment. This slide is about the multi-state, multi-payer ahead model. So it stands for States Advancing All-Payer Health Equity Approaches and Development. And the ahead model will open later this month. Right now, states are considering whether or not to apply. What applies to this conversation is that the ahead model sets statewide accountability targets for primary care investment. And also, as a part of this ahead model, the CMMI will release claims and non-claims definitions of primary care. So we'll be watching those as we develop this definition for OHCA as well. It is important to note that CMMI is not going to require states use their definition to measure commercial or Medicaid primary care spend. So we don't anticipate that this will become sort of a national standard, for better or worse, because first of all, relatively few states are expected to participate in AHEAD, and it's not going to be a required definition. All right, now I'm going to turn it over to my colleague Vinayak Sinha to talk through how states, some of the evidence for increasing primary care investment.
Thanks, Mary Jo, and morning, everyone. I think, as you all know, California, had a lot of success in discussing and thinking about primary care, and so OHCA will be kind of building on those efforts. Specifically here, we're talking about an effort by the Integrated Healthcare Association through work commissioned by the California Healthcare Foundation, which really found that increasing primary care investment does yield better outcomes. So, for example, in this study, which included about 80% of Californian commercial HMO folks, found higher spending on primary care was associated with better performance, both on quality and patient experience measures, including lower hospital and emergency department use and lower total cost of care. So these types of findings aren't unique just to California. On the next slide, we'll kind of look at a similar report and similar outcomes identified at more of the national level. So in 2019, a national study by the Patient-Centered Primary Care Collaborative and the Robert Graham Center showed that states with that higher primary care investment typically had lower rates of hospitalizations and emergency department visits, both of which can be particularly costly. So kind of evidence is coming in from California as well as nationally. And then on the next slide, what we see is that states that typically require that increased primary care investment do tend to see those increases. Most states tend to increase no more than about 1% of total medical expense to maybe 1.5% per year. And at this time, kind of all states are topped out at around 12%, as you can see from the Oregon percentage there. And it's also a little bit important here to note that these state definitions are different. The total cost of care in these states are also different. So this contributes to some of those differences in investment percentages and the actual amount spent on primary care. So definitions and measurement practices for states also do change over time. So some of that fluctuation there could be attributed to that. An example of that is, in 2022, Delaware's definition for primary care changed slightly to be a little bit more expansive, which kind of changes what that percentage looks like and the way that data submitters are contributing that data as well. On the next slide, we kind of look at the states kind of that are trying to measure primary care investment. There are now more than a dozen states that are at some stage of measuring primary care spending and trying to move more of the healthcare dollar towards primary care. A little later, we'll talk about those definitions and how those primary care definitions can vary considerably amongst these states themselves. One of the current efforts that's ongoing is from researchers at the Oregon Health and Science University that are supporting the Federal Agency for Healthcare Research and Quality in a new project to document methods being used to measure primary care spending and determine the feasibility of a national definition. As Mary Jo mentioned a minute ago, the AHEAD model does put forward a definition for Medicare, though not necessarily expecting that to be adopted as a national definition at this point. Though as of today, there are 5 states that require that a defined level of primary care spend for at least one payer type. And then others have set voluntary targets, like the voluntary benchmark that OHCA will be putting into place next year. At this time, I'll turn it back over to Mary Jo to talk through a little bit of our work ahead in California.
Thank you, Vinayak. This vision for primary care delivery in California comes from the California Quality Collaborative. It was developed in partnership with other California stakeholders. Many of you on this call may have participated in those conversations. We wanted to start with a vision for care delivery as it helps inform the development of the definition. For example, this vision references team-based care, which would suggest that a definition includes care provided by nurse practitioners, physician assistants, and other members of the care team. This vision was developed as part of a really extensive multi-stakeholder process, and we reviewed this with the primary care subgroup, and members noted some of its alignment with their thinking. They also referenced the need for sustainable and well-resourced primary care in order to achieve this vision. So we added that in over on the side. If you go ahead to the next slide, I wanted to take a minute to just talk through some of the lessons learned that we've seen from other state efforts. The biggest problem we tend to see is a lack of multi-payer alignment. Most states focus only on commercial or Medicaid, and there is little to no focus on Medicare or Medicare Advantage. So it's really hard for providers to transform care delivery for only a portion of their patients. Even with strong multi-payer alignment, it often does not make good business sense for smaller practices to hire additional care team members or make substantial investments necessary to transform care delivery. So shared resources can be very critical. As you might expect, it's challenging to reallocate healthcare resources to fund increased primary care investment in the short term. One stakeholder's increased investment is another's lost revenue, and that does bring challenges. It's also hard to determine the portion of certain non-claims payments, such as risk settlement payments, that were spent on primary care. And we'll talk more about this in a future meeting when we talk about allocating non-claims payments to primary care. All right, let's go ahead to one last slide, and then we'll stop and break for some comments and discussion. So, as OHCA considers how to develop a definition of primary care for the purposes of measurement, there's an important big picture question to consider. Are we trying to understand whether today's investment in primary care is sufficient to support access to core services like, standard office visits and preventive screenings? Or are we trying to better understand whether primary care investment can support the future vision of advanced primary care delivery across the state, essentially what we saw a couple of slides ago? We had a really productive initial conversation about this at the subgroup, and we thought it would be important to gain input on this question from the broader work group as well. So I'm going to turn it over to Margareta, and we'll have a few minutes of discussion on this topic.
Thanks, Mary Jo. Thanks, Vinay. Yes, so for, to this question, we would love feedback from this group about, how we could think about our definition. Is our approach more focused on core services, or do we want to more lean towards or think about that future vision? So open it up for suggestions, questions, thoughts. Yes, Kevin, go ahead.
Or maybe I'm just not a good Quaker and just can't take like silence in meetings too long. But so I don't mean to jump in. But first, I'm so delighted we're getting to this. So thank you. And I really appreciate the kind of prep work of the subgroup to help activate this. One question I had for the OHCA folks, and I have a feeling Beth Capel will weigh in on this too, maybe, but is what statutory authority really is in that? I appreciated you going back and starting, Mary Jo, with the what actually is in the bill that has empowered OHCA to start looking at primary care spend. But is there any teeth behind that in terms of, is it just saying it'd be nice if primary care investment achieved this benchmark, or is there actual authority to hold private payers, Medicaid, others accountable for achieving those benchmarks?
Happy to have Beth weigh in, but I will say that, based on our understanding, this is a voluntary, non-enforceable benchmark, and really our approach is through public reporting and transparency, and so demonstrating how how much we are spending on primary care in California, and also who's spending or who is spending on primary care in California. So really the approach will be focused on transparency and public reporting to start. And I don't know, Beth, did you want to add anything?
Well, since I was called on, I was waiting for Kevin because he's actually the expert here, but this piece, what I would say is part of the vision behind OHCA was that by transforming the way care is delivered, we could moderate costs while improving outcomes and improving equity. I mean, I just keep coming back to that very basic framing. What I have been surprised by in the primary care discussion is how much, and maybe I shouldn't have been, but how much variation there is in the definition of what's primary care, what services are included. Do you just do Medicaid? Do you do commercial? What about Medicare? Because I agree, cutting across all the payers is part of what will contribute to success. And so, and we may not, I don't know that we can't control Medicare, but we can certainly ask and try and influence how it delivers here. The other thing I would say is this work sets the stage where if we're not making progress at a future point, we can take additional steps to get beyond encouraging progress and start requiring it. You know, the important thing that the OHCA law did, and it's the first time ever in California, and there are a whole lot of people on this conversation that have contributed to this vision. It's the first time ever that we said, hi, we're going to prioritize primary care and behavioral health. Those are things where we're not doing the job the way we should. So this may be at an earlier stage in the conversation than Kevin would like, given the decades he and I have worked together on this and related topics. But it is, at least we're starting. And without this law and without this work, we wouldn't even be doing that. So that's the best I can do. Some other people will have more useful specifics.
Thanks, Beth. Catherine?
Sure. Thanks, Margareta. I would vote strongly for future vision. Not only is that more aspirational, I think it's actually required as I look at the statute. As Beth noted, there's not just variety in the definitions that are used for primary care. There's also tremendous variety in how and what is delivered today. So a goal of the statute was to, for example, increase access to integrated behavioral health. There's also specific notations in the statute around integration with public health and social services. That's not happening at all in most places. So I think to really live into the statute itself requires a future vision orientation. That's not to say it's not useful to understand services and spending on the ground today to inform it. So I don't know if this is necessarily an either or, but as we think about landing a definition and a measurement approach, I would strongly urge us to consider what we want primary care to be in the future to deliver on those goals of affordability and equity, and not limit ourselves to necessarily what's happening today.
Thank you, Catherine. Really appreciate that. And Adam?
Thank you. So I also think that we do want to keep our eye on to where we want to get to, but right now, I don't think many of the provider organizations truly have adequate insight into their current spend. If they're capitated and they have a whole lot of programs that they're doing and support, I don't think many of them have gone through the process of looking at what proportion of those dollars are spent on various primary care services, and even internally defining what they think those are, because sometimes it is a bit of a squishy definition. And yet there are groups that have pretty sophisticated services that they're providing. And so if we are too definite in our definition initially, we may not be able to capture some of those additional services that others are providing that could be included. So I think this is somewhat of a stepwise approach of having that vision to the future, but currently working on helping organizations to identify what likely should be included, how to get to the point where they're able to start to measure how much they're spending internally, and then that can surface some of those additional services that could be included as we move towards the future, which will get better defined with that additional information and sophistication.
That's helpful, and definitely something we're thinking about in terms of the definition. Like, are potentially there multiple definitions that we use, and are there different ways different approaches we could take to measurement to think about all the different types of services that need to be emphasized. And I think Reshma, I saw your hand up next.
Yeah, I'm gonna give a caveat. There's a 12-week-old baby next to me, so if you hear a scream, it's only because she's excited about primary care. But I completely agree with what was said, and I think one of the main things is when we think about value in care and thinking about costs, especially in primary care, we don't live in a silo. There are certain things that cost money, and that's a good thing. That's appropriate. So I think there's a merger, and I really like the last comment that was made about the vision in my opinion, should be future vision, because if we're really trying to create value, it is bridging silos and it is alignment across some of these different functions to support primary care in the right way. But when we think about what it means to create culture change across the state and thinking about spending specifically to the last point, there may be like I'm a stepwise person a lot with measurement and kind of from the last conversation we had about doing the stepwise measurement or accountability. It's the same way of there's ways to think about the future vision when you think about a practice reflecting on their own spending and how they do it in steps, right? So if you think about a future vision on where current state is, where that next movement, when you think about organizations or countries that have even moved primary care beyond traditional, there's a series of some steps, and some of this I pull even from Kevin, from the work you've done for years in thinking through that. But when we think about that in terms of spending, what does that mean? And I think being able to understand that can kind of bridge the two, both what core services are to understand what those are as a beginning point, but the vision still has to be the full vision. In other words, you're not going to achieve your outcomes. Move the needle.
Thanks, Reshma. And Beth?
Yeah, I just want to, we need the future vision. I want to ground us a bit in the on the ground reality today. The experience that folks in Sacramento with commercial coverage are having is that outside of Kaiser, primary care is not available readily. Sacramento is not some remote rural area. We're not talking about anything extraordinary here, but people who can't get an appointment with a primary care doctor, that's a bad place for us to be. And so I think as we have to, we want to have the future vision and get to a place. And I want to know whether the pediatrician for Reshma's young child counts as primary care or not, because sometimes it seems to and sometimes it doesn't. But I think we start from a pretty bad place is what I'd say. No matter what the percentages say, I think as with everything else we are working on, we have to look at market segment and approach. And I would say it's, ironically, as best I can tell, Medi-Cal managed care, primary care access is not bad. Specialty access is terrible. But if we're in a world where in Sacramento, commercial coverage outside of Kaiser does not provide primary care access, we've got a big problem. And we're starting from a very tough place. Thanks.
Thanks, Beth. And I think that kind of echoes a little bit what Bill Barcelona added in the chat, that maybe it's helpful for us to think about some policy goals around primary care and put the investment goal in the context of the broader, the broader concept or the broader context of how primary care is happening in California now. And, we won't be able to solve everything in this work group, excuse me, or, address all issues related to primary care, but we can kind of think about how the context influences how we set this investment benchmark. And Reshma, go ahead.
I just had a question in just understanding the slide a little bit more on what's included with core services versus future vision. So for example, there's a component of context that I think is coming up a lot in the comments around workforce and staffing and retention and, what we're able to do in terms of access, which is core to like getting to the outcomes we're trying to get to here. And does that count, for example, in like where do some of those components, right, that are kind of the context around delivering core services, is that actually a future vision, or is that actually, are we going to call out some of those things around access and retention as core service, right? because I think that helps make a decision on how to prioritize these. Was the primary care work group, is there a formal definition of what we're considering as core service versus components of what fits into future vision? Because I think I have a sense, but I'm actually realizing I'm just like filling in the blanks. I don't actually know how it's defined.
I mean, that's kind of the very question we're working through in terms of how, how to separate these two. But I guess, Mary Jo, do you want to add to that, or anybody else from the
Sure.
primary care subgroup?
Sure, I can add a little bit of context to that. So when I think of definitions that really focus in on core services, it's really core services, right? So it's your office visits, it's preventive screenings, it's codes related to, administering vaccinations. It's the basics. It's sort of those core primary care services. As we think about future vision, what that often includes are things like expanded care teams that can support care coordination and management, integrated behavioral health services, connections to social supports and services. And so those are sort of the buckets that we tend to think about. But I actually think you raise a slightly different question, right? Which is, what's our plan to sort of achieve each of these outside of investment, which I think is a different question.
Yeah, because the reason, so that was actually super helpful. And I think it emphasizes the future vision being so vital not to lose here, because they're integrated, right? So I'm thinking myself, right, real practically from operations, I can't get to core services because of funding and because of my inability that there's no one to hire. All of the health systems are trying to hire the same 3 people in the city of Sacramento. And so because of that, I'm going to care management and all these other, what you're calling future vision support systems to achieve my core services. Like they're one and the same and interlinked. And so I can't separate them out to achieve goals from a practical perspective. And so for me, that I think that highlights this point that everyone's making, and kind of highlighting even further that if that's the definition we're using for future service, that's core service, unless we do increase the funding and the ability to retain, right? There's a whole other burnout issue here, but that may not be our focus, but it's in the context, right? So I think they have to be interlinked.
Great. Adam, go ahead.
So I wanted to add on to these comments. So I agree with what Beth said about access being a challenge, but I think at this time, access to primary care is a challenge because primary care physicians, for the most part, are still paid on a fee-for-service basis. And so if the schedule has an empty slot, that's dollars they're not making. And then there's no addition, and then there's the funding issue where there are no payments coming in to support the additional staff that we would consider that still primary care in our future vision, or potentially, as was just Reshma just noted, truly should be core services. So right now, it ends up being somewhat circular as we enable different payments to help primary care providers and their organizations broaden the services that they're providing to help the population. Then they can start to limit the number of patients that they are trying to put in their schedule, because they are getting paid to manage a population instead of being on this fee-for-service treadmill. And that's when access starts to improve, because now my population is limited and my goal is to help you stay better. So that's why I think this is a progressive definition, and we can't start just at the future. We want to have a vision where we're going, but we really need to start at the basics right now.
Well, isn't that why we put all 3 of these together in this work group?
That is very much the intention in terms of calling out the interconnections. Yes. Yeah, Monica, do you want to jump in?
Yeah, I'll be really quick because I know there are others waiting, but this debate is a really critical one. I think I was in clinic last week and talking to a young primary care doc that had left primary care. It was a capitated environment. So again, it wasn't because of a fee-for-service treadmill. She took a lateral. So she didn't do it because of money. She didn't do it because it was too high acuity. She actually was in urgent care with me, seeing extremely high acuity folks in a transitions of care clinic, which she preferred. And it was mostly about the team-based stuff. So Reshma's point is like so critical, right? She was like, here I am, like I am doing all the check boxes and there were no standing protocols for my nurses. And it was all of the operations on the ground level. And so I do think like, is our trickle-down economics going to really solve for that or not? And the debate about core versus future is so, so critical, I think, to that. And I know we've been talking about primary care definitions and we haven't been including things like in the core services, nursing visits, because it's very hard to tease out what's primary and specialty care. But there's something in this space that I think is worth us continuing to talk about. And maybe in the primary care work group, you guys can help us just advance this concept a little bit more.
Yeah, really good flags. Go ahead, Catherine.
Sure, I was just going to offer a comment on Beth and others. I would caution us not to limit whether it's core or future vision and definitions out of fear of workforce shortages. Those are very real issues in Sacramento and honestly all across the state. And it's one of the reasons that OHCA has as a charge workforce stability, with this idea that as we increase investments in primary care, increase investments in behavioral health, the workforce will stabilize in healthy and effective ways. So I would really encourage us, again, whether we go with core or future, to set a definition that sort of delivers on population needs, and then identify, invest in the workforce development efforts that are required to deliver on that. But I think it's frankly quite dangerous to limit yourself in terms of aspiration, definition, mechanics out of fear that there won't be people there to deliver it. It isn't a chicken or an egg. One comes first and the other follows.
Thank you, Catherine. And sorry, I'm trying to check if there are other folks with their hands raised. Oh yes, Amy, go ahead.
Yeah, I definitely agree with what Catherine and Bill said, and really the majority here. The only one thing I wanted to add as we think about, definitions, expansion, and is my I guess contribution would be to really look at SDOH and how are we going to collect that data as we respond to the population's needs, right? As we respond and look at access and equitable care. I know, right now, it is not measured in primary care. However, do we challenge ourselves? Do we challenge our state, to really look at these services and put it in as part of the spend? Because we all know, those of us who deliver care, that it is so intricate and a part of the spend. And I think we need to start somewhere and we need to collect that data. And are we collecting that data in a very systematic, thoughtful way? And I don't think we are. So I just go back to, when we look at and defining whether it's core or future, we should definitely call out collecting that data and be very purposeful in the way that we do it.
Thanks, Amy. And just as a follow-up question, do you see a connection between, addressing social needs or addressing social determinants of health and the definition of primary care investment, or how do you see that connecting?
Yeah, I mean, and I would love to hear others, welcome your thoughts. I think that if we don't call that out in collecting that data, right, in really procuring these data points and elements, we're not going to move the needle, unfortunately. So I would challenge all of us to put that in as a service that, the entire care team should be accountable, right? Maybe even the health plan. But everyone who has a responsibility or is accountable to the patient along their continuum of care should be able to do that. And then do we have a process to do that in a validated way, right? To really collect that data. because I do see, you know, where the puck is going to land, and everyone's going to be looking at California, right? How are we doing this? And we could, you know, lead in that way to really make it, I don't want to say mandatory, but required to collect this data.
Thanks, Amy. That's a really good consideration. And I think it's something we can both consider in the context of primary care and then also our alternative payment model standards.
Yeah.
Yeah. Kevin, go ahead.
I appreciate the comments, and I think Sony's comment brings us to the reality at the front line of, I mean, it's a crisis. It's really, primary care is collapsing. And I share a vision with all of you. I think here, I could tell you great, performing primary care would be a whole team. At the core, you need clinicians. It would be family doctors like me, other physicians, I think other clinicians like nurse practitioners and physician assistants. Then you'd have this wonderful multidisciplinary team with integrated health, behavioral health, people working on substance use issues, enough social workers and community health workers to address people's social needs. I'm not sure just screening for social needs is the key. I think it's just a team attuned to knowing their patients and being able then to respond appropriately. So I share that. The problem is, for where we're at right now, that core is about to become extinct. And if we don't start with a real priority there and starting to measure that, the risk is that we can then start counting all this stuff. And I worry particularly about things that are very centralized in larger healthcare organizations. So, I don't know, those of us in the group who actually work in primary care, do you really notice it when an organization said, oh, we have this great team at the IPA level or the medical group or the ACO level who's doing all this care management and doing all this population health work? It doesn't always actually translate to feeling that is actually helping me in my day-to-day job. So I think there's a real slippery slope here that's a risk for just us understanding the baseline spending. I mean, I get it for a future vision, but that you can start to layer on all this stuff that says, maybe we're spending a lot on primary care, but it's a lot of extraneous stuff that is really not at the heart of primary care. And to me, it's just, if we don't put in that investment and make it a more attractive career and really build the team, starting with simple things like enough medical assistants, some community health workers, some social service personnel built into the practices, we're just going to be in a worsening spiral of crisis in primary care. So I'm a little wary of sort of the baseline of measuring too much that gives us a bit of a misleading view of how much resources are really being put into the core functions of primary care.
Thank you, Kevin. Yeah, I think that's a really helpful and key consideration for us as we think about the definition and, thinking about different ways we could approach the definition and, whether there are multiple definitions or kind of different things we could do to both measure what's core and where our future vision is. And Catherine, one last comment before we have like 2 more slides we wanted to get through. Go ahead.
Oh, absolutely.
Catherine.
And I'll be quick because I think Kevin's comments are very compelling. I guess for me, what would be helpful, I mean, one, I question, is it really an either or? Could you do both? And what is the purpose of the measurement approach? Is it to understand what's happening on the ground today or to inform the target? Because if it's understanding what's happening today, I think Kevin's absolutely right. The core services is where you go, but ultimately we want to set a target, and that target should be sufficient for the future primary care. So maybe just say a sentence of, can we actually do both? Like, could this be a both and? And is there a different approach when you're measuring to inform what is today and then measuring to set a reasonable target for the future?
Great. And sorry, Reshma, I'm going to keep us going, but would want folks to keep the chat going, and also we can come back. We just wanted to get through, I think, like 2 or 3 more slides. So go ahead, Mary Jo.
Thank you, Margaretta. Just wanted to take a minute to walk through the primary care investment measurement decisions that OHCA will be considering in collaboration with all of you and the subgroup members. So first, include a narrow set of services, an expanded set of services, or all services performed by primary care providers. Speaking of, include a narrow or a broad set of providers as defined as primary care. How to incorporate behavioral health services and or providers. We sort of separate this question out from other members of the care team because it brings its own set of considerations and trade-offs. Similarly, how to incorporate OBGYN services and or providers. Some definitions include OBGYN services, but only when performed by a primary care provider. Should the definition be limited to certain places of services? So places of service. So for example, is care delivered at an urgent care primary care? Same for a retail clinic or many other care sites. Whether or not to include pharmacy spending in the denominator. So often the decisions that we make about what to include in the denominator is that sort of, if you think about primary care as a percentage of total spending, what's in the denominator tends to impact that percentage more than any one decision about what goes in the numerator. There's been a lot of discussion today about, can we measure this different ways to support different use cases? One approach to do that is by creating a modular definition where you essentially stack on different components of primary care investment to support that. And then how should non-claims payments be apportioned to primary care? In December, our meeting coming up on December 6th, the technical subgroup is going to make recommendations for the work group to discuss. Any recommendations that they do not work through in December, they'll work through in January, and we'll continue that loop of bringing information back to you for discussion and consideration. If we just go, I think we have one more slide of content and then just some next steps. All right. So this slide previews some of the strategic questions that the work group will discuss and consider in future meetings. So how to set the benchmark. Should there be a single benchmark or benchmarks for each payer type? Should there be separate benchmarks for children and adults? Should the benchmark be absolute, relative improvement, or stair step? This is sort of similar to the conversation we had around APM adoption goals. And then should the benchmark be based on percent of spending or a defined amount? And next, I'm just going to turn it over to Margareta to wrap us up on our next.
Thanks, Mary Jo, and sorry if we cut the discussion a little bit short, but again, really welcome your feedback in the comments and via email, and we'll continue these discussions both in the larger work group and the primary care subgroup. So just to close us out today, as next steps, as I mentioned earlier, we will be sharing the draft APM standards and implementation guidance and the goals with the advisory committee to solicit their feedback, and then come back and debrief related to their feedback in a future meeting. And then also in December, moving forward to December, we have another meeting of our primary care subgroup where we'll really dig into recommendations on measurement decisions. And then we'll talk about in our larger work group meeting in December, the subgroup recommendations on primary care investment decisions. So we'll kind of dive into more details about all the questions Mary Jo laid out in our next work group meeting in December. So I know we are about a minute over time. So again, really appreciate all of the feedback and discussion today. And we, of course, welcome any feedback offline via email. And we will see you in December. Thank you so much.